Next up is a fellow Texan, Dr. Nathan Wiederhold from UT Health San Antonio, is going to talk to us about the challenge of non-Aspergillus mold diagnosis. Nathan?
Hello, everyone. Let me get to the point of sharing my screen here. Well, again, thank you to everyone for attending this virtual symposium today. And I'll try to wrap it up a little bit, talking about challenges of non-Aspergillus mold diagnostics. Here are my disclosures. Now, here are the EORTC, MSGERC criteria for proven disease by invasive molds. Now, one of the criteria that's included is the amplification of nucleic acid in tissue with sequencing when molds are seen on histology. Now, why is this important? Well, this is important because we know that there are a large number of medically important fungi. Overall, it's estimated that there might be greater than 12 million different fungal species, and approximately 700 of those, and this is growing every year, have been associated with infections in humans and animals. So in this table, I show some examples of different fungal orders and genera of molds of medical importance. Now, we have to keep in mind that within each of these genera, and many of these genera, there are multiple species that have been associated with disease in humans. And so these numbers are continuously growing. Now, that being said, there are several groups that we commonly see in at-risk populations. So this slide here shows several different graphs taken from the TransNet study as well as the PathAlliance study. And I think you can appreciate in three of them, where it's shown in green, Aspergillus species are the most predominant ones. However, in each of those, there was a mixture of other molds that were associated with infections, including members of the Mucorales, Fusarium, Scedosporium, endemic fungi, as well as what was called the other mold group. And that other mold group was actually quite a broad category, as shown kind of toward the bottom right of the slide within the gray box. I think you can appreciate there were numerous different genera that were cultured from these patients. In fact, in the PathAlliance study, they reported actually that in 11.4% of the patients, multiple different molds were actually recovered within that surveillance study of solid organ transplant recipients. So I think this shows us that there is a lot of variety of different invasive mold infections, different invasive molds that can cause infections in humans. So why is this important? Well, I think you also know that the infecting organism does influence treatment decisions. We know that there can be major differences in vitro susceptibility between different genera of fungi, as well as even between different species within the same genera. And we also know that there are differences within treatment outcomes associated with fungi. Several of these listed here are actually can be pan-resistant to antifungals or even resistant to amphotericin B, which is often used as broad spectrum therapy when we're unable to make a species identification. Now, when we start the process of trying to diagnose a fungal infection, in many instances, it starts with histopathology. And the reason we start with this is because it can provide insight into tissue invasion as well as inflammatory reactions. Histopathology is also relatively standardized and relatively cost-effective. And when combined with other laboratory-based assays, the diagnosis of invasive fungal infections can be enhanced. However, it does have some limitations. This is an invasive procedure in order to acquire tissues in most cases. And even though the diagnosis is enhanced when combined with other laboratory-based assays, concomitant samples are often not submitted for laboratory studies. For example, in one study out of Washington University in St. Louis, only 16% of histology cases also had cultures specimens submitted for other laboratory-based studies. I think the important thing is that it's difficult to provide a species or even sometimes a genus level identification, which is based on morphology. We know that several of the septate hyaline molds are very, very difficult to distinguish amongst each other solely based on the morphology seen within tissues. And if you look at some of the studies that have been published, one of the common errors that's actually been reported in the literature is the inability to correctly distinguish between Aspergillus versus the Mucorales. And of course, as you know, that can have marked or significant treatment implications. In addition to histopathology, culture is also often used, but we know that cultures of tissue and respiratory tract specimens are very insensitive. In one study out of MD Anderson Cancer Center, the sensitivity ranged between 58 to 30%. In autopsy confirmed cases, it was only 53% of those that were culture positive, where in those that had histological evidence of the fungus being present within the tissues, only about 30% of those were culture positive. In addition, in certain circumstances, it might reflect colonization rather than invasive disease, and they are subject to laboratory contamination as the fungal Canidian spores are ubiquitous in the environment. Furthermore, as previously mentioned, they do not yield information in real time. Now, immunohistochemistry can also be used. It's available and has been for some time for Aspergillus, Candida, and Mucorales. However, the specificities are poorly defined against many other fungal species, including several members that are part of the hyaline molds that are also very difficult to distinguish just purely on morphological characteristics seen within tissue. Because of this, immunohistochemistry is not recommended for genus or species identification under the revised EORTC MSGERC guidelines. Now, for the diagnosis of invasive fungal infections as a whole, we know that there are several different methods available, as highlighted in this table published by the Fungal Diagnostics Laboratories Consortium. However, as also noted by this group, there are several diagnostic gaps that include the lack of availability, the lack of standardization, as well as the lack of knowledge and capabilities in many laboratories. Now, while these gaps can hold true for the diagnosis of all invasive fungal infections, I think they're especially true for non-Aspergillus mold infections. Now, throughout this symposium, there have been descriptions by others about the great effort that has gone into the establishment and validation and clinical use of novel diagnostic platforms. We've learned about the lateral flow assays that are now being used for the diagnosis of infections caused by Cryptococcus, Aspergillus, Coccidioides, as well as Histoplasma. Dr. Koo provided a very nice overview of volatile organic compounds, or what some have referred to as breath biopsies. And then, of course, Dr. White just mentioned molecular-based assays, including those that are laboratory developed, as well as some now that are commercially available and approved for use, specifically those from Diagnostics. However, it's important to point out that those have not yet been cleared for use in the United States by the FDA. So despite all of the efforts and advancements that have been made, there's several different issues that still have to be addressed. Are these going to be commercially available assays versus laboratory developed tests? What are their clinical performances in different patient populations? Will they be specific for certain genera, or are they able to detect and identify a broad range of fungi? And is genus level, if that's what's achieved, is that enough? What are the ideal specimen types? We've mentioned serum, plasma, BAL, urine, and now breath as well. And as well as what are the influences of other factors such as antifungal exposure, as well as environment and host factors that can also sometimes influence the results of these different diagnostic platforms. Now, what I'd like to do is talk a little bit about some of the molecular assay issues. As previously noted, PCR is now recognized as appropriate for the detection of invasive fungal infections from tissue samples, but only when fungal elements or structures have been detected by histopathology. So there has to be evidence of disease in order for this to be truly useful. It's not recommended in cases where fungal staining is negative. Now, as noted by Dr. White, our standardization techniques for molecular assays are improving, but currently there are no ISO or CLSI guidelines yet available to help assure that protocols and interpretations are reproducible between laboratories. And there are a few validated studies demonstrating that these results are indeed correct. Now, one of the problems with molecular assays is that we really don't have a good gold standard for which to compare them to. Cultures have been considered the gold standard for microbiological diagnostic assays, but as mentioned previously, their sensitivity is quite low. Therefore, when molecular detection and identification are more sensitive than culture, what often is used as the gold standard, the true sensitivity and specificity of the assays cannot be determined, and we're unable to prove if the organism identification is indeed correct. This has issues in terms of the validation because misclassification probabilities do exist for new tests, including sensitivity, specificity, as well as negative and positive predictive values, as well as others. Other issues that can occur with molecular-based assays. What happens, what do you have to work with if fresh tissue is not submitted to the laboratory for a molecular-based platform, and therefore you have to rely on something that might have already been fixed in formalin? Well, we know that that can cause shorter fragments as well as cross-linking, making these assays particularly challenging. If you're using pan-fungal primers, they've recognized most fungal taxa, and therefore you can have also amplification of contaminating fungal DNA. Colonizers, as well as airway contaminants, or in other words, are also amplified. Now, you can try to overcome this by using species-specific or genus-specific primers and probes, more of a quantitative real-time approach. But in practicality, there's a limited number of species that you can amplify. And then remember, given the large number of different types of molds that can cause disease in humans, this can be quite problematic. In addition, as with cultures, we do have to worry about laboratory contamination resulting in false positive reactions. This not only includes potential contamination that might occur with the ubiquitous nature of different fungi within the environment, but also contamination of reagents and fungal DNA, as Dr. White had previously mentioned. Now, one thing I want to briefly talk on, and Dr. White also touched upon this briefly in his presentation, is that of the microbial cell-free DNA sequencing that's now coming to fruition, and more publications are being shown in the literature. So this is a different approach in which you're not actually using tissue, but they're using plasma in order as to be the specimen for which to do the amplification of nucleic acids, and then sequencing and analysis in bioinformatics. Now, there are numerous publications that are coming out every month now, it seems to be, but I wanted to highlight one out of Washington, the University of Washington. This was a study, a retrospective analysis of specimens that were from a well-characterized cohort of hematopoietic cell transplant recipients with pulmonary invasive mold infections. Overall in this study, the sensitivity and basically being able to identify either one or more pathogenic molds was at 51%. Interestingly, sensitivity for invasive aspergillosis, being able to actually detect and determine to the species level in patients with proven or probable invasive aspergillosis was lower, is at 31%. In contrast, in those patients who had a proven or probable invasive mold infections due to a non-Aspergillus species, the sensitivity was higher at 79%. They did report seeing no false positives, and so the specificity overall, at least in this retrospective analysis, was 100%. Interestingly, several members of the cohort that had proven or probable invasive aspergillosis and had aspergillus detected also had another mold that was sequenced and identified. The question then becomes what to do with the interpretation of these multiple microbial species. And I don't think we have a good handle on that just yet. Now, the advantages of this technique is that it's non-invasive. It's a plasma sample versus a tissue biopsy. Hence, the name liquid biopsy has been applied to this metagenomic approach. And you are able to get species level identifications. There are certain challenges, though, as well as limitations. It's not widely available at most centers. The performance in different patient populations is undefined. And as previously mentioned, how to interpret the results with multiple microbial species, including ones that might not have been expected to come back on the report. Now, there have been numerous editorials written about this new metagenomic approach. Some of them are listed in this table. I don't want to read every single one of them, but I do want to highlight a few of them, including how will host factors, including immunosuppression and clinical status, be used to triage patients. These are not inexpensive assays. In addition, will they be combined with other laboratory tests or as standalone? If combined with other laboratory tests, when will they be used? Up front to potentially avoid extensive workups, or late when other methods are negative or inconclusive? In addition, will these be developed in-house, or will they be sent out to reference laboratories, thus increasing the turnaround time for results being available to clinicians? And again, how to interpret the results with multiple or unexpected organisms are present. A few other challenges for invasive mold infections is with regard to antifungal susceptibility and resistance. And I think Dr. White did a very nice job of highlighting several of the aspects associated with this. Currently, susceptibility testing is primarily performed by phenotypic assays, hence it requires a culture. And as previously mentioned, cultures are oftentimes negative in patients with invasive mold infections. In addition, once you have a culture and perform a phenotypic assay, oftentimes an interpretation cannot be provided unless it's a specific Aspergillus species, such as Aspergillus fumigatus here in the United States, where the CLSI has now established a breakpoint for voriconazole, or in Europe, where UCAST has set breakpoints for azoles against a limited number of Aspergillus species. For many invasive mold infections, other than Aspergillus, breakpoints just are not established, and ECVs are also rarely available for many of those species. In addition, one thing that's probably going to be a major limitation, at least in the short term, for the use of molecular assays for antifungal susceptibility and resistance profiling is that we're still trying to grasp a better understanding of the mechanisms of antifungal resistance for many molds. We're still learning a lot about azole resistance in Aspergillus species. For a while, we thought it was solely due to mutations within the CYP51 or its promoter region, but now we know that mutations within other genes independent of CYP51 might also have a role. For example, in our group, and has been published by others, 25% of the isolates that are phenotypically resistant to the azole might still be wild type for CYP51. Now, we are making headway in understanding antifungal resistance mechanisms in other molds. Here are just some snapshots of some publications that have shed light on different mechanisms of resistance in species other than those within the genus Aspergillus. But one thing we have to ask ourselves is, will there be a market to drive the commercialization and availability of such assays in the future? Or will these only be available as laboratory developed tests at certain centers or reference laboratories, therefore further limiting their effectiveness because of the turnaround time that will be needed for that? Finally, one thing that I think many of you in the audience might appreciate is that there are numerous changes in fungal taxonomy and nomenclature. And this has primarily been driven by molecular approaches and enhanced phylogenetic analyses that have been ongoing now for several years. This, of course, can lead to a disconnect between the clinical and mycological literature. I provide some examples of genus level name changes that have occurred over the last 10 years. Of course, this is not an all-inclusive list. So one thing we're going to have to start asking ourselves now is when to adopt these changes, not only for societies and organizations that publish clinical guidelines, as well as CLSI and UCAST that publish breakpoints and ECV documents. But this also has major ramifications for diagnostic device manufacturers on when to include new names in their libraries. And even at the laboratory, individual laboratory standpoint, the laboratory information systems also have to be updated. So that's a question I think we're going to have to adopt. We're going to have to respond to in the near future. And again, that's not specific for invasive mold infections other than Aspergillus. This really applies to all of clinical mycology as a whole. So in summary, non-Aspergillus invasive mold infections, while relatively rare, they have a low prevalence in many at-risk patient populations. There's a large number of different genera and species that can cause disease in humans. The numbers are increasing on a yearly basis, and we have also created some confusion with changes in taxonomy and nomenclature. It's important, though, I believe, and I think others would agree, that we really need to get to the species level identification if possible because of differences in antifungal activity profiles as well as clinical responses. There is a lack of commercially available and regulatory cleared assays. This is especially true for invasive molds other than Aspergillus. It's a small market. But I think as you all can appreciate, the late diagnosis can lead to poor outcomes in many at-risk patient populations. Laboratory developed tests are available, but then you have to ask about the reproducibility of the results between different centers, and they're not often widely available. They're often used at certain centers where they have populations at high risk for invasive mold infections and in reference laboratories. And when they have to be sent out, this leads to a less than optimal turnaround time. Finally, there's a lack of a gold standard. Cultures are still used, but they lack sensitivity, and that really limits us from fully understanding the diagnostic performance of new assays. Again, many of these challenges apply both to Aspergillus as well as non-Aspergillus mold infections. Now, finally, what I would like to leave you with are the characteristics of an ideal diagnostic platform. These include early detection, good sensitivity and specificity, as well as species level discrimination, the detection and identification to the species level, if possible, of a broad range of pathogens. They need to be reliable and reproducible, as well as have the ability to quantitate in order to distinguish between diseases and colonization. If possible, it'd be great if they were non-invasive, as well as widely available and affordable. Now, of course, I think you realize that there's no current diagnostic test that meets all of these criteria. This is really a search for the Holy Grail, but I truly hope our quest doesn't turn out as so. And with that, I thank you, and I think we'll open it up to questions at this point.
Thank you so much, Nathan. That was a great sort of summary for the non-Aspergillus molds and the difficulties we encounter in the reference lab. We do have a few questions in the chat. The first one is from Dr. Samadar, who's asking, how's the performance of broad range PCR in formally fixed tissue? Can we rely on it for accurate speciation?
That's a good question. I think in some instances, you probably can, at least to hopefully a genus level. I do question about whether or not it might be accurate to the species level, especially if we're thinking about more rare invasive mold infections.
Very good. And then we have Dr. Archana Keche. When we isolate unusual species of Aspergillus or other molds from respiratory specimens, how can we know if they're pathogens, basically? Can we differentiate between colonization and pathogenicity?
That's a very good question. And I think you can't just solely rely on the laboratory tests for that purpose. You also have to take into account findings that might be available on histopathology. And of course, the current patient and how they are presenting. We definitely can see invasive infections caused by more rare Aspergillus species as well as other rare mold species. But everything has to be taken into the context of the patient and how they're currently doing. And so that definitely can be a challenge from a clinical diagnostic standpoint.
Very good. From Lewis White. Nathan, do you think the higher sensitivity for detection of the non-Aspergillus molds by the plasma NGS reflects the increased angioinvasive nature of these molds, mainly the mucorales?
I definitely think that could be playing a role. If you look at that one study that I presented that was published in 2021, the species that they primarily saw were the mucorales, such as Rhizomucor, Rhizopus, and some other genera. And we know that those are highly invasive and also highly angioinvasive as well. So I think that definitely could play a role. One of the things about these, liquid biopsy metagenomic approaches is that we really don't know how well they're going to perform in other patient groups, especially on a prospective level. The study that was presented was retrospective, had a collection of specimens that they had stored from a very well-characterized patient population. But that really doesn't truly reflect what the clinician who's trying to make a diagnosis in real time is going to see. And so I think it's yet to be determined just how well that approach is going to play out in more of a real world setting.
And another question from Lewis. In the absence of breakpoints, do you think the presence of genetic markers of resistance can aid interpretation when we have a culture with a raised MIC but no breakpoints? Right.
And so that's an interesting question. I don't know if I've really thought about that before. And so kind of going back to the question that you answered previously, Dr. White, in your presentation was with regard to should you trust the molecular results versus the phenotypic results? I would have to agree with you at this point in time. I would trust the phenotypic results over the molecular, but of course that could change in the future. If there is a discrepancy, where I think it would tend to lie is in the phenotypic results would have a higher MIC and the molecular results might actually show a wild type, at least for the targets that are being assessed. What to do if you have a high MIC, so you have both a phenotypic result and a molecular result that are showing basically mutations that have been associated with resistance. Sometimes though, I think it's previously mentioned, those molecular results don't always correlate very well with the degree of MICs that we see, because there could be multiple things that are occurring at the same time. And so the phenotypic results, of course, will just show you the overall susceptibility or resistance profiles as a whole, whereas the molecular results might zoom in on one factor, but might miss something else specifically if it was not being looked for.
Thank you so much. I think we're right on time. I'm going to, we have one more question. Is there any commercially available NGS kit that performs well for diagnosing IFIs?
Not that I'm aware of at this point in time. I think the field is still in its infancy, and so it's primarily in laboratory developed tests. Of course, there is Carius, as mentioned by Dr. White. But as far as I know, that's the only commercially available lab that's doing it. You have to send the specimens to them, and so they provide you a kit for collection. But then the actual specimen is sent to them where they run their specific assay and do the bioinformatics analysis based on the results and then generate a report for you.
Great. So as I was saying, we're right on time. I'm going to turn it over to our host to explain the breakout session.